So I will go ahead and introduce both of our speakers this afternoon. Elena Martinez is a physician assistant in endocrinology with clinical interest in type 1 diabetes and metabolic bone disease. She is originally from the Midwest, attended undergraduate school at Villanova University and graduate school at Midwestern University, working as a PA at Children's Hospital in Las Vegas prior to her move to Seattle in 2020. Elena enjoys traveling, reading, hiking, and keeping stats at the Mariners games. Dr. Nandy Munchie is a clinical associate professor in endocrinology and diabetes division at Seattle Children's. She grew up in the Northeast and completed medical school at New Jersey and pediatric residency in Philadelphia, after which she moved out west to Seattle for pediatric endocrinology fellowship at Seattle Children's. After completing fellowship, she joined the faculty at Seattle Children's, and her clinical practice included seeing patients with all endocrine disorders, including diabetes. She took on the role of medical director for the division in 2022. Dr. Nandy Munchie enjoys traveling with her family, cuddling with her dog Apollo, and reading and cooking new recipes. So with that, I will let Elena begin the presentation today.
Our presentation is about type 1 diabetes screening and prevention, and Millie is going to present the first half.
Great. Well, good afternoon, everyone. We're all both excited to be talking about this topic. So as we all are aware, type 1 diabetes is a chronic autoimmune disease that has both genetic and environmental contributions, and these result over time in an immune-mediated loss of functional pancreatic beta cells, which leads to symptomatic diabetes and then lifelong insulin dependence. About 2 million Americans have type 1 diabetes, including over 300,000 children and adolescents. And the annual incidence of type 1 in youth is around 18,000, with a prevalence of 1 in 300. We understand that that type 1 diabetes is a disease continuum that begins prior to its symptomatic manifestations. The risk of developing symptomatic type 1 diabetes can be identified and quantified, and that's part of what we'll be talking about today. And we can characterize this disease into well-defined stages and describe the rate of progression to symptomatic disease. This is a pretty new and exciting area of clinical medicine and pediatric endocrinology. And the screening and prevention program has really come about since the FDA approval for the first disease-modifying agent for type 1 diabetes, which we will review later in the talk. Next slide. So just to start off, neither Lainey and I have any disclosures. Next slide. And just to go over some objectives of today's presentation, we will go over the stages and presentation of presymptomatic type 1 diabetes mellitus. We'll also talk about current screening recommendations. And then, as I mentioned earlier, we'll talk about the role of teplizumab in delaying progression to clinical type 1 diabetes, and then when to refer to our current early T1D service at Seattle Children's. Next slide. So this is really our present understanding of the continuum of type 1 diabetes. This paper was published about 10 years ago now. And what you can see are the different stages, so stage 1, 2, and 3. On the bottom is time, and then on the y-axis is your beta cell mass or functional beta cell insulin production. And so in the first stage is when is really the start of type 1 diabetes. These individuals who are on the stage have positive antibodies, 2 or more diabetes antibodies, which we'll talk about in a sec. And during this phase, the immune system has already begun attacking the insulin-producing cells. However, there are no signs or symptoms of diabetes, and blood sugars essentially are normal. As we progress to stage 2, these individuals again still have continued autobody positivity. However, now they're showing some abnormalities in their blood sugar metabolism, whether it be impaired fasting glucose, impaired postprandial glucoses. However, there are still no signs or symptoms and they do not meet criteria for frank stage 3 diabetes, which is the next stage. This is when the clinical diagnosis typically takes place. These are typically the patients who present with our usual symptoms: polyuria, polydipsia, fatigue, weight loss, etc., and require insulin administration at this stage. Next slide. So thinking about risk of diabetes in general, so we do know that first-degree relatives of individuals with type 1 diabetes have a 15 times risk of developing T1D. Additionally, folks that have a personal or family history of autoimmune conditions such as celiac disease or autoimmune thyroid disorders like Hashimoto's or Graves' disease also have an increased risk of developing T1D. However, we know that an overwhelming majority, close to 90% of patients who present with new onset type 1 diabetes have no known family history of type 1. Additionally, one of the reasons that this is important is that screening for autoantibodies has been found to reduce presentation of stage 3 T1D in DKA by greater than 50%, which is really helps with their initial diagnosis and care, and making sure that they're not sicker than they should be. And this has been shown by doing ongoing metabolic monitoring for disease progression once we know that they do have positive antibodies. Antibody testing is probably most critical in the early childhood time frame, as the rate of progression from multiple antibodies to clinical disease is more rapid in the very young. And so that's why we are presenting this topic today, and we think it's an important thing to talk about. Next slide. So just a little bit more about risk of progression. So once you have positive antibodies, so for individuals in stage 1, as I mentioned earlier, these are the individuals who have two or more positive diabetes antibodies, however, do not have any symptoms or abnormal glucoses. Their 5-year risk of developing stage 3 or clinical diabetes is 44%, their 10-year risk is 70%, and their lifetime risk approaches 100%. And then when we move to individuals in stage 2, so again, as a reminder, these are the individuals who have 2 or more positive diabetes antibodies, as well as some level of abnormal glucose metabolism. Their 5-year risk is 75%, and again, their lifetime risk approaches 100%. Next slide. So we really wanted to jump into how do we screen for this? As I mentioned, the first kind of marker of showing whether or not somebody has stage 1 type 1 diabetes is the diabetes autoantibodies, or the islet cell autoantibodies. These 4 are the ones that are described in the diagnostic criteria in terms of American Diabetes Association, as well as the ones that are clinically available. And then additionally, there is another antibody that you might see that is mainly used in clinical research trials. So if you have any patients who come to you that have been involved in any of the research studies out there in terms of screening for type 1 diabetes, they may have this particular antibody on the bottom here positive, which still counts, but this one is not really clinically available in terms of testing. Next slide. So in terms of how to screen, there are a few different ways, and we'll talk about the options that are available to our community providers. So a commercial lab would be one way to go in terms of getting antibodies done and screened for. Our lab, you can send, if they're somewhat local, you can send patients to our lab here at Seattle Children's. It's called the islet cell autoantibody panel. It measures those 4 antibodies that I described in the last slide. Our lab sends it out to Barbara Davis Center out in Colorado, which is a big diabetes center. And so we do send it out there because we know they have great sensitivity and specificity at their lab. Additionally, LabCorp, Quest, and Mayo also have panels, and I've listed the names here below as options. these would, again, go through patient's insurance, and we'll talk about cost in a second. And then once we do recommend outside of these to make sure that it's a CLIA or CAP certified reference laboratory. And we do know that about 1/3 of positive screenings that have one antibody that are positive are often followed by a negative confirmation test. And so that might be part of the screening modality that we use. And we typically will recommend repeating it, and we'll talk about kind of timeframes on when to repeat that in a follow-up slide. Once an individual has confirmed two islet cell antibodies positive, then it would be important to follow up to develop a follow-up plan at that time. Next slide. These next options are current research studies. So these are no cost options for type 1 diabetes antibody screening. So probably the most well-known is TrialNet. It is a national study. These are for individuals who are between the ages of 2 and 45 years and need a first-degree relative with type 1 diabetes. However, we can also screen for individuals between ages 2 and 20 who have a second-degree relative with type 1 diabetes, and they themselves have not had diabetes diagnosed. There are centers across, and they can also mail you in-home test kit for testing. Pretty convenient, pretty quick, and only a very small blood sample is needed. You can make an appointment at one of our locations as well for families to get tested. Next slide. Another helpful research study out there, this is run through Colorado, is called the ASK study. And this is for any US children ages 1 through 17. So they do not require any family history of type 1 diabetes. And this specific research study, which is autoimmunity screening for kids, looks at both screening for T1D as well as celiac disease. More locally, we have the Northwest Research Institute that's run by Bill Holopian, who's on many of our T1D studies here in the Pacific Northwest. This is more directed, looking at risk of genetic risk of type 1 diabetes, and then we'll offer antibody testing to those at high risk, because they would approach newborns and their parents in that newborn period to see if they would be willing to get tested for the genetic risk, and then antibody testing would be offered if needed. Next slide. And then in terms of just what to use in helping you send these lab orders, if you are doing commercial lab screening, or if you're documenting in your chart in terms of risk for type 1, these are some helpful ICD-10 codes that might come in handy. The first couple are just reasons for screening. So screening for DM, at risk for DM, family history of DM or other endocrine diseases. And the last three are actually specific diagnostic codes for the different stages of early T1D. So stage 1, again, with the antibody positivity, but without any symptoms or glucose issues. Stage 2, 2 positive antibodies with some mild glucose issues, and then stage and then unspecified stage if you're unclear where they are in their progression towards clinical type 1. Next slide.
Thanks, Millie. Thanks again, everyone, for coming to our talk. So we realized pretty early on that this is a lot of information, very new to everyone on the clinical side of things. So we developed this algorithm that can be found on our Seattle Children's website for primary care providers. I'll just briefly walk us through it. So the algorithm starts out with identifying patients that are at higher risk. Like Millie mentioned, we do recommend screening first and second degree relatives of people with type 1, as well as persons that have any family history of other autoimmune diseases. So checking those autoantibodies. The ages that we suggest are buckets of 1 to 3 years, 5 to 7 years, 9 to 11 years. And if all those testings are negative for these high-risk persons, we suggest checking those kids for autoantibodies again at 13 to 15 years. We do recognize that for these patients that are not high risk, you can still consider screening any child due to that vast majority, 90+% of new onset cases of type 1 diabetes occurring in people without any significant personal or family history. As Millie mentioned, these autoantibodies can be checked with commercial labs, but we have links here for some of those research studies that Millie mentioned. Once the screening is positive, the sort of breakdown here is if there's no positivity of any autoantibodies, the patient is currently considered at low risk, continue regular pediatric care. If they're one of these high-risk persons, rescreen in these age buckets. If they have one or more positive, we are accepting all referrals of those patients to our early type 1 diabetes service at Seattle Children's. Specifically, if they have 2 or more, we put a suggestion here to consider an oral glucose tolerance test, but that's not expected necessarily from the primary care group. We're happy to discuss everything after the positive autoantibodies with the patients once we see them in early type 1. But 2 or more, they're at higher risk of progressing to clinical type 1 diabetes sooner. So there's this suggestion of an oral glucose tolerance test. If it's just one autoantibody that's positive, no further action outside of the referral to our clinic. With the oral glucose tolerance test, the results sort of help stage, as Millie mentioned, what stage and progression they are of type 1 diabetes. And then the rest of this will continue to be discussed in our clinic. So again, this algorithm is on our website, and we do continue to update it. It actually just had some updates this month. So once you refer patients to the early type 1 diabetes clinic, they are seen by either Millie or I. We also have a specific nurse that works in our early type 1 service. She is a certified diabetes educator. They are seen by both dietitian and social work, who also specifically have training and background to understand this presymptomatic type 1 class of patients. And then Child Life can see patients as well that are coping with this new information. And then if there is any needs as far as needle phobia or other things like that, Child Life is a really great resource that we have in our clinic. We talk about stages of type 1 diabetes, where the patient currently seems to be in the progression. We definitely talk about signs of DKA, high blood sugars. We review how to monitor blood sugars. We talk about some things that can be worked on or changed as far as glycemic index and total sugar intake, as well as exercise that could potentially prolong the life of beta cells. We do definitely talk about the psychological and psychosocial impact of the early type 1 diagnosis. We discuss eligibility for research studies, if applicable, and then for all of these patients, we will continue to monitor them closely as they progress through the stages of type 1 diabetes. Specifically for stage 2 patients, we talk about pharmacological interventions that could potentially delay the progression from stage 2 to stage 3. We talk about the side effects and monitoring. We talk about insurance coverage. And then those patients, we also continue to monitor closely until stage 3. So currently there is just one FDA-approved medication to be used in children with presymptomatic or early type 1 diabetes, so stage 2 specifically. But there are many other medications that have been showing some promise in preserving beta cell function. The FDA-approved medication, as Millie mentioned earlier, and I'll talk much more in depth about here, is teplizumab, MZWB, Tzield. This is a monoclonal antibody. The other medications that have been shown to have promise in preserving beta cell function, most of these have been tested in early stage 3, so shortly after diagnosis of clinical type 1. And they're sort of all in different stages of where they're at in their clinical trials. Diamyd specifically, this last one listed in the section of showing promise in preserving beta cell function, is currently in a phase 3 clinical trial, which is the last step before FDA approval. However, their indication is specifically for patients with a specific genetic marker that can cause or be contributing to type 1 diabetes. So it would be an even smaller eligibility. And then our local research institution that Millie mentioned as well, Benaroya Research, their current studies regarding medications, pharmacological interventions to preserve beta cell function are listed here. So we definitely talk to patients about both research opportunities and current FDA-approved medications. There are additionally cell therapies that are being studied and looked at for patients in presymptomatic or early type 1 diabetes. None of those are currently FDA approved, but that's another exciting area of intervention for these patients. So Tzield is the medication that we have experience with so far in the early type 1 space. It was initially FDA approved in November of 2022. The maker of this medication is Sanofi, who has been in the diabetes space for some time. They make Mellitus, if you're familiar with it. This medication we've given to 2 patients now, and we have another patient that's scheduled upcoming. We gave Tzield to the first patient at Seattle Children's in November of 2024. So this medicine is a CD3-directed monoclonal antibody. What does that mean? So as you're likely familiar with, type 1 diabetes is an autoimmune disease. This means that the body is typically the immune system is supposed to recognize foreign viruses and bacteria, mount a response. In autoimmune diseases, just to review, your body sort of gets confused and starts to attack some area of your own body. In this case, it's the beta cells of the pancreas, whose job is to make insulin. So the way that Tzield works is it tries to target that immune response. It specifically targets T cells, which are a type of white blood cell that are part of the immune system. They help fight infection. Typically, each T cell can only fight one type of virus. But the CD3 receptor that is on the T cell is what the Tzield medication is targeting. This receptor is present on all T cells, and it's a surface structure associated with the T cell receptor. The actual mechanism of how Tzield affects the CD3 receptor and sort of turns off the pancreatic beta cell destruction is, as far as I know, not fully understood, but it has been proven to be helpful in these patients to delay the progression of type 1 diabetes. So who is this medication approved for? It's currently approved for patients in stage 2, and it's currently approved for patients aged 8 and older. We are still accepting referrals and seeing patients that are younger than 8 years of age for some of those other aspects that we talked about outside of pharmacological intervention, but it is just good awareness that currently this medication is approved for 8 years and older by the FDA. So it's approved for patients in stage 2, which, to repeat again, is patients that have 2 or more autoantibodies to islet cells that are positive, and they have some form of dysglycemia or high blood sugars. So the standard staging process and the sort of gold standard in the research side of things was the use of the OGTT or a fasting blood sugar. So a fasting venous drawn blood sugar of 100 to 125 is representative of stage 2. And then 2 hours after the OGTT, a blood sugar of 140 to 199. We've kind of expanded with some guidelines that have come down from the ADA and some large consensus groups that additionally blood sugars over 200 at the 30, 60, or 90 minutes of an OGTT or A1C, sort of in what we traditionally think of as in the type 2 world, the pre-diabetes range of 5.7 to 6.4. That's also considered dysglycemia and consistent with stage 2, or a 10% increase in A1C from baseline. Patients that are not eligible for Tzield are patients that have a clinical history suggesting type 2 diabetes. Certainly if they have overt hyperglycemia consistent with clinical stage 3 diabetes, so if their fasting blood sugar is above 125, if their 2-hour OGTT is above 200, if their A1C is 6.5 or above, kind of your well-known diagnosis of type 1 diabetes. And then another exclusion, because the safety is not known yet, is for patients that are pregnant or planning to become pregnant. So the benefit of TZIELD, the clinical trial included 76 patients. It was a randomized, double-blind, placebo-controlled study. It had patients aged 8 to 49 years old in stage 2 of type 1. The initial study followed patients for 51 months, and then the extended study followed patients for 923 days. The initial study showed an average, when compared to placebo, of a 2-year delay of moving from stage 2 type 1 to stage 3. The extended study, which again followed patients further, showed that average to be closer to 2.7 years. So this is a data graph from the study. So on the y-axis is event-free probability, or 1. On the y-axis is no type 1 diabetes, no clinical stage 3 type 1 diabetes. And you can see time is on the x-axis. Over time, the light gray line shows the placebo versus the orangish color line shows TZIELD, patients that were given TZIELD in the trial. And you can see the difference in how quickly patients with a placebo versus TZIELD were diagnosed with stage 3. On average, this graph is from the original study, so it was about 2 years, but again, the extended study was about 2.7 years difference. So the approval for TZIELD in these patients aged 8 and up in stage 2 is an infusion medication. So we will see these patients first. We will discuss everything else that I already mentioned that are discussed in these visits. And then if there's interest and if they're in stage 2 to talk about TZIELD, we'll talk about the medication. We typically obtain insurance prior authorization first before any scheduling is done. The medicine is given 14 consecutive days, and the infusion itself lasts 30 to 60 minutes, but we have seen that those visits can last some additional time. Patients have an option of either having an IV that can last up to 3 days, that's changed throughout the full 14 days of the daily infusions, or they have an option of a PICC line. So far, all of our patients have selected the IV, so we have more experience with that, but we are hopeful to have just see what having a PICC line for these patients, how that's helpful. There is close monitoring with lab work before insurance approval is even sought, and then definitely before multiple infusion days, and then afterwards as well. The most common side effects to this medication, which we will review in depth with patients, are the cytokine release syndrome, decrease in white blood cells, and rash. Cytokine release syndrome is a response to the medication in which we see fever amongst a host of other symptoms. Most patients in the study did not have cytokine release syndrome, and no patients needed to discontinue the medication because of this. The decrease in white blood cells is expected in response to the medication because this medication is an immune modulating medicine. So the white blood cells actually sort of go into body tissues and therefore have a lower count when you're testing the CBC. But those numbers rebound actually throughout the later infusions, and then values return to normal within 4 weeks or so. And then the rash, there were many different rashes seen. All of the rashes in the study resolved without intervention. So far, one of our patients had a very mild rash for a couple of days. So these patients, after they get TZIELD, we do continue to follow them closely with our early type 1 service. We continue to see if there is potential for other medications for them as well, same as for our patients that have not received TZIELD, and then we prepare them for life with stage 3 type 1. And then just to mention, so far for all of our patients, we give these infusions in our infusion center at Seattle Children's. So our endocrinology clinic is right across the street, but it's in the main campus hospital. It's the same infusion center that patients get infusions for all kinds of things. So it is an outpatient infusion, and they just come in for their appointment with the IV obtaining lab results. We give them some pre-medications to help with side effects as well. The visits are taking 2 to 3 hours, but then they can go home that same day. And then this last slide is some other resources about early type 1, TZIELD, screening for type 1. So these will be available and are really helpful to further educate on the presymptomatic type 1 stages. Also to talk about health insurance and coverage of both screening for type 1 and medications. And then there's some helpful things at these websites for communication with patients and families. I think that's all we have to present. I'm not sure, Patty, if there were any questions that came up while Millie and I were speaking.
Yeah, no, oh, yep. Hold on, I have to open my chat up. I can't see this on my screen here. So a question is, do the insurance plans cover the labs that are recommended?
You want to take that, Millie, or I can comment?
It seems like they generally are. We got some data where I believe, and Lainey, correct me if I'm wrong, I think the average cost was around $14 out of pocket for most patients who were getting these antibody testing done.
Okay, feel free if there's any other questions to put it in the chat. Just wait a couple minutes.
You see, were the other questions addressed already that are in there?
Yes.
Okay.
Unless you see one I've missed. I don't see one I've missed. I think Dr. Mandy Mushy answered one through the chat.
I see a follow-up on that one. So the first question was how many we've treated in our clinic, and just to review again, we have treated 2 patients, and we have 1 scheduled later this month. In terms of how many possible patients were interested, we have quite a number, and I think Lainey might have a closer number of how many patients have come in through the early T1D service. Again, some of them are younger and not eligible for the medication, but Lainey, you might have some more details on that number.
I think we've seen now a total of 30 patients have been referred for positive autoantibodies that we've seen.
We did receive another question. Can you clarify specific criteria for who to screen?
Yeah, that's a tough question. I think there's varied recommendations out there. And so on our algorithm, we try to focus on the higher risk patients. So again, any individual with a first degree relative with T1D would be probably the highest and probably the most interested, to be honest, in terms of getting screened. However, also higher risk would be anyone with personal autoimmune history for themselves, so individuals with celiac disease or autoimmune thyroid disease. We've actually had some discussions with our GI colleagues here at Seattle Children's to think about discussing screening with their celiac patients. And then as well as thinking about screening any individuals who might be interested, maybe they heard about it on the news or on TV, if they have family history of other autoimmune diseases. We hope to have some more discussions with our other colleagues here, such as like rheumatology and things like that, with other kind of more common autoimmune diseases, and see if screening would make sense. And then, I mean, really, you could screen anybody because, and there are some discussions about just general population screening for T1D antibodies. Again, because such a large population of patients who present with T1D clinical stage 3 do not have any family history of autoimmune disease or type 1 diabetes. So you could really consider that. Now, thinking about just time and for everybody, you know, I'm sure you're not going to be able to discuss something like this with every single patient that comes through your door. And that's why we kind of suggested to start with those, especially if anyone comes to you with interest because they've heard about it.
Are there any other major side effects?
The most major side effects are the cytokine release syndrome, specifically low lymphocyte count, and rash are the most common. There have also been seen changes in other values in the blood count. There's been seen changes in liver enzyme counts, so we monitor those throughout as well. I think those are the most common that I can recall. Millie, I don't know if you recall any additional.
And I think you covered the hematologic, the liver, the skin rash, and the CRS, I think are the main ones. And then, you know, allergy, anaphylaxis, hypersensitivity as well, just like any other medication.
Yes, and we do monitor the patients after the first at least 6 infusions for an hour afterwards to watch for that anaphylaxis allergy reaction.
Another question, should GAD 65 be screened first and others if that is positive, or are you recommending screening all autoantibodies at once?
I'd probably do all of them at once. Many of our younger kids don't have GAD positivity, but might have like an insulin antibody positive and not the GAD. So I would probably recommend just doing the whole panel.
And then another question, if you are screening for antibodies in an asymptomatic or low risk patient, would you also get the HA1C and fasting glucose insulin level?
Oh, good question. I would probably, if they're totally asymptomatic, or if they're like low risk, as you mentioned, without any maybe family members, I probably would not. We can always do that when they come to see us if their antibodies are positive. If their antibodies are negative, probably don't need all that additional information.
Part of why I just wanted to add on, part of why the screening is thought to be helpful is that the autoantibodies can show up well before disease. So that would be helpful to know in thinking of timing of testing for just autoantibodies versus B1C or blood sugar.
And then the next question was, are there any long-term side effects?
Of the teplizumab, it is a new medication for this sort of specific indication. It hasn't been given for other indications before, but it has been in studies since the early 2000s, and there are many, many patient years of data that have shown no additional side effects outside of the side effects that are seen during and shortly after the infusions up till this point. So hard to say longer term than that, but before just the study for patients with stage 2, it has been tested in research in many different studies, like I said, since the early 2000s.
Okay, thank you. So I'm not seeing any other questions come through. So thank you both for taking time and doing the presentation, and thanks everyone for joining. I also just wanted to mention I did a few minutes ago throw in the evaluation, so please go through your chats and take a couple minutes. We'd appreciate your feedback. So thank you very much. And we'll be following up with an email as well, as I mentioned, with the link to the recording if you want to listen to it again. Thank you.
Thank you.
Thank you.
Thank you, everyone.